Thank you. So, as you were mentioning, from the Eastern Mediterranean region, now that might sound, it's just a WHO kind of designation, so often people don't know what does it mean, what is, there are countries which should logically be there and there are countries which should not be there. So basically, Eastern Mediterranean region extends from Pakistan in the east to Morocco in the west. So it includes the Middle East, the Red Sea littoral states, the Levant, and then North Africa region. So it's around 700 million people. And if you were to sort of say that what are the defining characteristics of this region, the one obvious is the emergencies. That if you look at the countries which are there in the region, about half of them are having protracted humanitarian emergencies, whether it is Afghanistan, it's Yemen, Syria, Iraq, Libya, and now more recently, the flare-up in Palestine. So why that is important? Obviously, we know that the rates of mental health problems have been relatively stable over the last 20 years, although the numbers have gone up, certainly. But the fact is that in emergencies, if you look at the rates tend to be about just over 22% among people who have been exposed to adversities in the last 12 months, as opposed to around 13% in the general population. So there is significant increase. And as you would see, that the Eastern Mediterranean region has one of the highest rates of mental health conditions in the world. It's the second highest, actually. And almost all of it can be accounted for because of prevailing emergencies in the region. And secondly, the thing is that in the Eastern Mediterranean region, there are countries which are among the poorest in the world, like Yemen, for example, Somalia, and they're the countries which are the richest in the world. I mean, you have Saudi Arabia and you have Qatar. And at the same time, this is a region which is going through very rapid social, political, cultural change. Now, the change which has happened in this part of the world, or US, over 200 years, is taking place in a span of 40 years. And there is a huge number of migrants for economic reasons, besides for humanitarian reasons. And consequently, that puts a lot of strain on the population's mental health, as well as on the systems which are supposed to take care of them, whether they are healthcare systems or social care systems. And those systems haven't had the time to evolve. And it's also not giving populations the time to internalize the changes which are taking place and consequently develop this resilience. And as you would see, that both the disability-adjusted life years in terms of burden and particularly in terms of years lived with disability, in this region there is a significantly high burden. And similarly, you can see a significant difference between countries which are experiencing emergencies and others which are not. I mean, we have been talking about zero suicide. Just to remind you that both the SDGs and the Global Action Plan, they are only one indicator in the SDG related to mental health, and that's around suicide mortality rates. And the Global Action Plan, which has been updated and is now relevant until 2030, again has a specific indicator on suicide. Both of them are talking about 1/3 reduction by 2030. That is not contradictory to zero suicide, because I was talking to someone here in the morning and I was saying that zero suicide, there is no time. It's not time bound. In this case, it's time bound and we are almost halfway through the SDG time period. Now, looking at this region, you would see that generally in this region, the rates of suicide per 100,000 are lower than the global medians. It's around 6.4 per 100,000 as opposed to around 10 per 100,000 globally. But if you look at the countries, some of the countries like Somalia, for example, and Djibouti, they have higher rates. And the reason for that, I'll come to as I go along in a minute, that why is this happening. Similarly, most of these suicides are occurring in low and middle income countries rather than in high or high middle income countries, which is just about what is seen globally as well. When we were doing this recent review, which was published, I think, last year, what we were finding out is that the most common means of suicide in these countries seems to be hanging themselves, followed by pesticides, and then it comes to firearms, drowning, etc. They are relatively less common as compared to this problem. Similarly, when it comes to the resources, what we are seeing is that majority of the countries do seem not to have any specific suicide strategies or action plans. And the ones which are there, the 4 of them which are standalone, are relatively recent. I think most of them are post-2015. So it's less than 10 years that most of the countries, and like I think you were mentioning in the morning, that often these strategies are not linked with clear action plans, and resource implications are not there. So that obviously means that often they are gathering dust on the shelves in most of the, even in the countries which they are there. And this is a slightly different kind of concept, what is meant by functional. Functional simply means what I was mentioning, that there have to be clear resource allocations, both human and financial. Otherwise, we do not classify that as a functional suicide prevention program. And as you can see from here, that group 3 countries actually are the countries with the lowest resources. Group 2 are the middle income countries, and group 1 are the high income countries. So again, it seems to be the group 2 countries, and often group 2 countries are also the one which have the highest number of educational institutions. Often people who are graduating from those institutions are migrating to either group 1 countries or to the Western sort of countries. So it's no surprise that you would see that there are more functional programs in those countries. I mean, it's Egypt, Tunisia, Lebanon, etc. Those are the middle income countries, and Iran. Now, one of the things which I think somebody was talking about in the morning was about primary health care. And one of the indicators which we are looking at when it comes to suicide prevention as well as mental health in general is how well it's integrated into the primary health care system as well as the general health care system. And we're using these 5 criteria: the availability of guidelines for recognition and management of common mental health problems, including suicide, availability of pharmacological and psychosocial interventions, and training. And I think it was music to my ears when somebody mentioned about, training without supervision. Actually, it's just fun and games. I think you were mentioning it too. So that's what you would see, that generally speaking, when it comes to availability of guidelines, availability of training and supervision, generally speaking, this region countries are doing all right. And what is also, you might be surprised to see, is that most of the countries which are doing well on these things are the ones in emergencies. I mean, Syria, for example, you look at Iraq, you look at Libya, these are the countries, because post-emergencies, and I can tell you the stories, that when I went to Syria for the first time in 2008, the doctors, the directors of health were very clear in saying, we do not want these mad people roaming in our wards. We don't want mental health in general hospitals, period. Right? They are fine in these big hospitals outside the cities. We're happy with that. Now they are insisting that, yes, we want to have small acute care units in all the general hospitals. But the problem is that most of the workforce has migrated out. So how do you do that? That's the question. So that's where this issue that let's train up people working in primary health care. But unfortunately, there are rules, regulations which are making it very difficult to have pharmacological interventions available, because one of the problems which we are often facing is that you conduct all the trainings, you look at all the supervision mechanisms, and the rules simply say that the doctors cannot prescribe psychotropic medicines, period. Because for whatever the concept is at the higher levels of policy making, that these are addictive medicines, these are dangerous medicines, and so on and so forth. So general doctors are not allowed to prescribe, let alone anybody else. And psychosocial interventions, in a number of countries, there is no concept of having clinical psychologists. There are a number of psychologists available when you look at the numbers, but when you want to find out are there any clinically trained psychologists, you hardly find any in the country. And in the region, there are about 8 mental health professionals per 10,000, as opposed to around 13 globally. And in the European region, it's around 50 per 10,000. So you can see there is a marked discrepancy there. So there is nobody there actually to provide psychosocial interventions. Then the legal status. This is something which we have tried to sort of cross-check a number of times, although there are still countries from where there are reports that suicide is being criminalized in those countries. Recently, we had a number of correspondence with Egypt and other countries, 1 or 2 other countries. And when we reached out to them, they said that, look, we are not criminalizing suicide per se. What we are saying is that anybody who assists somebody else, he or she would be prosecuted. And essentially, we are targeting the terrorism and so on, the suicide bombing, and we are not targeting people with problems and people who have attempted suicide. So it's not that we have criminalized suicide per se. But then when you start, and often when you read the text, it's very clear that yes, that's exactly what it is saying. But unfortunately, what gets out in the media is that this country has criminalized suicide. So that's what we had to try to sort of go back to the countries and their legislatures and find out exactly what is said, and we looked at the text and so on. So that's what we have at this point, that about half of the countries do criminalize suicide. It has been there on the books for ages, and given that majority of the countries' laws have been there for a long period of time, and generally updating the legislation takes about a decade on an average. So that's the reason. Similarly, when we look at the media coverage, generally speaking, majority of the countries do not, the media houses do not follow the guidelines on media coverage. Mostly, I mean, if you look at the recent one from WHO, it came out in 2017, which gives fairly explicit guidelines as to what can be done. And similarly, when it comes to gatekeeper trainings, you would see that in this region, relatively fairly low proportion of gatekeepers are trained, although when it comes to media professionals or doctors, it seems to be all right, doing about the same as what the global medians are. Majority of the countries, particularly during COVID, this has been given a flip, and lots of countries have started having these telepsychiatry clinics, hotlines, helplines. They are there. Most of the countries now have them. Most of them are maintained through volunteer networks, except for 1 or 2 countries like Qatar and Tunisia, for example, which is manned by mental health professionals. The challenges obviously remain, and one of them is data. That, remember when I was talking to you about that some countries, Somalia, for example, or Djibouti, have very high rates, and I keep on getting these very nasty messages from the ministries of health that how come next country, Sudan, has, low rates, and Djibouti has such a high rate. And the problem is that none of the countries is providing data. We are basically relying on estimations and projections. And given that Djibouti and Somalia would be compared to African countries of the same socioeconomic status, and the rates in African countries of the same socioeconomic status are higher, so consequently, when it comes to estimation and projections, their rates tend to be a bit higher, without thinking that because this religious aspect is not being factored into those estimates. Rather than comparing it to the countries across the Gulf, like Yemen, which might probably give them more accurate results. So we have to explain the whole procedure, that where is these figures coming from. So, and I was looking at some of the countries which provide data, and it's only about 30% of the countries actually in the world which are providing real-time data. So in most of the rest of the world, it's guesstimates essentially, when you talk about suicide rates, right? So, and obviously then the cultural and religious factors are there. I've already talked to you about the emergencies and the vulnerable sections of society, which are, and lack of availability of most of the psychosocial interventions in majority of the countries. Because even when psychosocial interventions are available, they are fairly restricted to either large cities or capital cities at the most. And the coverage is fairly low. I was mentioning about the data quality, and you can see that in majority of the countries, particularly when it comes to suicide, hardly any country is able to provide reliable data in the region. Now, what we are trying to do is that in the region where I am, we have done 2 or 3 things. During COVID, generally speaking, as you know, mental health hardly gets any money. But during COVID, suddenly there was a lot of interest in mental health, and the interest was not restricted to health. It was the prime ministers and the head of state suddenly saying that mental health is extremely important, and money started coming in, although it has stopped again. So we were able to set up a platform which is available if you go to our website on WHO EMRO. So initially it was related to COVID and talking about how to manage stress. But we have been able to add modules on suicide prevention as well as substance use prevention and safety planning, and all these tools we have put it on there. So anybody from any of the countries, not only in the region, but anywhere in the world actually, can log in and access that website. In addition to that, given that one of the cost-effective interventions is about responsible reporting in the media, we tried to sort of see what is the situation in the region, and we went through this process of developing media monitoring tool, which is available again on our website, and we have started implementing it in a few countries because obviously we need to look at the interest in the countries which is there. And currently we are at this stage where we are doing some trainings in specific countries: Morocco, Tunisia, Lebanon, Palestine, Pakistan, and Iran. At this point are the countries in which they are starting to monitor the coverage of suicide-related issues in the media. And what we are trying to focus on at this point is English language media generally, although we are trying to support the countries in modifying it and contextualizing it so that they can start looking at the local language media houses. Secondly, we have developed this school mental health package. Again, as you know, one of the key interventions and with evidence for cost effectiveness is about life skills education or social emotional learning. So we have this package which has been available. You can access it, and we have converted it into an online course. Basically, it is targeting school personnel, whether they are school teachers, counselors, or school nurses. So those are the three categories which it's targeting. And it's not related only to suicide, but also to other common mental health problems in children and adolescents, including bullying, suicide prevention, substance use, and so on and so forth. Right? And it's basically color-coded. When you look at the manual, it's color-coded for severity of the condition and what interventions can be done by family members, what can be done by staff, and what can be done by the counselors. So it's color-coded in those manners. In addition to that, like I was mentioning about the gatekeepers training and so on, we generally are using the MHGAP intervention guide, which I suppose some of you might be aware of. That's the mental health gap intervention guide, which among the modules is suicide. But like I think the previous speaker was mentioning about, it's not what is to be done, it's how to be done. That was the problem, that everybody talked about integrating mental health, which has been there since 1978. But why is it not happening? And that's why we thought that let's look at a system-based approach. So essentially, this primary care integration tool looks at the health system in terms of workforce development, financing, availability of drugs, and other tools. And at the same time, it looks at monitoring, evaluation, advocacy, and policy and leadership. So it takes these 6 building blocks of a health system and tries to identify how mental health can be integrated using each of these building blocks and what are the tools which are available. And in addition to that, these are fairly heavy books, so we understand this might not be possible. So we tried to convert it into an online course, which is a slightly heavy course. It's about 65 hours. And the thing is that if you do not complete a module, you won't be able to go on to the next one. But you would get a certificate at the end if you persist. So I'll stop here, and if there are any questions, I'll be happy to take them on. Thanks. Over to you.